Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 460 of our pharmacotherapy series, which majors in pediatric malignancies. This video involves patient JOB, whose case was discussed in parts 458 and 459 of this pharmacotherapy series. After completion of his induction and post-induction treatments, JOB is scheduled to receive maintenance, continuation, treatment for a total therapy duration of 2.5 years from the start of his induction therapy. His parents question why treatment will be of such a long duration and ask whether this is necessary because JOB is already in remission. What is the purpose of JOB's maintenance or continuation treatment for acute lymphocytic leukemia? Which agents should be used in JOB for this phase of therapy? Maintenance or continuation treatment sustains the complete remission achieved from induction chemotherapy. Early trials have shown that without maintenance treatment, the majority of acute lymphocytic leukemia patients will relapse. Patients who have successfully responded to induction and post-induction therapy may still have a high leukemic cell burden, although undetectable, which must be eradicated by additional treatment. This is supported by the results of bone marrow biopsies from patients who have experienced relapse after several months to years of treatment. The cytogenetic characteristics of the leukemic cells in relapsed patients are identical to those at the time of diagnosis. Maintenance therapy is also supported by the results of MRD studies, which demonstrate that some amount of measurable leukemic cells are still present months after the completion of induction therapy. Drugs that are effective during induction therapy cannot, by themselves, sustain remission during maintenance therapy. However, other agents are effective in sustaining a complete remission. Two of the most effective drugs are mercaptopurine and methotrexate. Methotrexate is most effective and least toxic when administered intermittently, usually on a weekly basis in oral doses of 20 mg per meter squared per week. Mercaptopurine is effective and well tolerated orally when dosed daily, usually at a dose of 50 to 75 mg per meter squared per day. Other agents have been added to standard maintenance therapy with mercaptopurine and methotrexate to improve remission duration and to increase a patient's chances for long-term survival. There is evidence that monthly pulses of vincristine and prednisone offer advantages, lower bone marrow and testicular relapse rates, in standard risk patients as well. At present, most contemporary treatment regimens for childhood acute lymphocytic leukemia have intensified induction and post-induction phases during approximately the first 6 months. These early intensive treatments typically are followed by a less intensive maintenance therapy consisting of methotrexate and mercaptopurine in combination with periodic intrathecal chemotherapy treatments, either with or without intermittent vincristine, prednisone pulses. The available evidence suggests that a patient like JOB with standard-risk acute lymphocytic leukemia will benefit from use of daily mercaptopurine 50 to 75 mg per meter squared orally and weekly methotrexate 20 mg per meter squared orally or IV, along with periodic pulse therapy with vincristine 1.5 mg per meter squared for 1 day, and either prednisone 40 mg per meter 2 or dexamethasone 6 mg per meter squared orally for 7 days every 4 weeks. In addition, intrathecal methotrexate should be repeated every 8 to 12 weeks. After 8 weeks of maintenance therapy with the aforementioned regimen, JOB has had an absolute neutrophil count that has ranged between 2,000 and 3,500 cells per microliter for more than 6 weeks. Other hematologic and chemistry findings are also within normal limits. Should any changes in his maintenance therapy be considered at this time? Are there any potential problems with mercaptopurine and methotrexate that could explain his absolute neutrophil count values? Could normal absolute neutrophil counts increase his risk of treatment failure? Diurnal variation of methotrexate concentration and marked interpatient variability in absorption and metabolism of mercaptopurine have been described, which may explain the varied response among patients to standard doses. Most patients are able to tolerate full doses of mercaptopurine, which is inactivated by the enzyme thiopurine S-methyltransferase, abbreviated as TPMT. It is known that approximately 89% to 94% of patients have high thiopurine S-methyltransferase activity, 6% to 11% have intermediate activity, and 0.3% have deficient activity. Patients with deficient thiopurine S-methyltransferase activity experience severe and even fatal toxicity with standard mercaptopurine doses and require very low doses, approximately 10 mg per meter squared 3 times a week, for avoidance of profound myelosuppression. Patients receiving half doses of these agents have shorter remission durations. However, even those who tolerate maximal protocol dosages may also be at greater risk of relapse. Patients who are able to tolerate maximal doses without significant myelosuppression may require doses that are higher than protocol initiation doses. Some protocols allow for dosage increases of methotrexate or mercaptopurine every 4 to 6 weeks to maintain a target absolute neutrophil count in the range of 300 to 2,000 cells per microliter. This is usually accomplished by alternately increasing the doses of mercaptopurine and methotrexate by 25%. In this situation, dose increases of one of these agents are performed every 4 to 6 weeks. JOB has a normal absolute neutrophil count and is tolerating therapy. Therefore, it is reasonable to attempt to intensify his chemotherapy dosing. For JOB, this means an increase in mercaptopurine from 50 mg per meter squared per day, or an increased methotrexate dose from 20 to 25 mg per meter squared per week. Although parenteral administration of methotrexate provides more predictable levels and improved compliance, it does not consistently improve the results of therapy. To assess whether JOB is receiving an adequate dose, weekly WBC counts are essential. This allows his treatment team to accurately appraise the adequacy of his dose and to follow his disease status to ensure that remission is continuing. If an inadequate degree of myelosuppression is demonstrated, JOB's compliance should be investigated because decreased compliance is a frequent problem in the therapy of childhood acute lymphocytic leukemia. At least one investigation has found improved compliance with evening administration of mercaptopurine. My next question to you reads: how long should JOB's maintenance therapy be continued? Most centers treat children with acute lymphocytic leukemia until a total therapy duration of approximately 2.5 years for females and 3.5 years for males. Most patients who experience relapse do so during therapy or within the first year of completing therapy. After the second year of therapy and for every year thereafter, relapses become much less common but are occasionally observed. Some centers are exploring whether more intensive treatment protocols could decrease the duration of maintenance treatment because the current duration is based on data from less aggressive protocols. Until there is more conclusive evidence regarding the duration of acute lymphocytic leukemia maintenance therapy, patients with JOB's characteristics should receive chemotherapy for approximately 2.5 years. We will now look at asparaginous preparations. Asparaginous is available from two natural sources, Escherichia coli and Erwinia chrysanthemi. These two preparations are not 100% cross-reactive, so the Erwinia product may be substituted for the Escherichia coli product when hypersensitivity reactions occur. However, one should be aware that cross-reactions occur in 17% to 26% of patients. Because of the shorter half-life of the Erwinia product, a dosage increase of Erwinia asparaginus is necessary to equal the activity of the Escherichia coli product. Of note, patients receiving equivalent doses of Erwinia asparaginus have a poorer remission rate and survival than those patients receiving the Escherichia coli asparaginus. In contemporary protocols, the dose of Erwinia asparaginus is typically about 2.5 times greater than the Escherichia coli asparaginus dose. The incidences of rash and silent immune clearance appear to be equivalent for these two preparations. Escherichia coli-derived asparaginus is available in a long-acting form known as PEG aspargus. This agent is formed by covalently linking monomethoxy-propylene glycol to Escherichia coli asparaginus. PEG aspargus has a prolonged half-life of 5.8 days compared with 1.2 days for Escherichia coli asparaginus and appears to be safe and effective, even in patients with prior reactions to Escherichia coli and Erwinia asparaginus. The prolonged half-life allows for less frequent, i.e., every 2 weeks, dosing of PEG aspargus than for the natural source asparaginus products, i.e., 3 times a week. Asparaginus compounds derived from different Escherichia coli strains may differ in both enzyme activity and half-life. At least one study has reported an unexpected mortality rate in childhood acute lymphocytic leukemia associated with an assumption of equivalence among different Escherichia coli asparaginus preparations. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 461.